So thank you for inviting me to speak today to David Lyle again. So I'm just going to give you a brief run through on imaging of the paranasal sinuses, mostly concentrating on what things are important for the surgeon to know. So it's always important for the radiologist to have a good relationship with the surgeons that they work with, and Ben thankfully has left the room, so he won't get too cranky at me for this photo. But for a radiologist, it's important for us to get feedback about what we're reporting, and not all of us have the great relationship that Mitesh and Ben do with a surgeon, for them to be able to feedback on cases. So hopefully today I'll help you with some of that. So what I'd like to talk about is basically what the role of the radiologist is when reporting sinus CTs, run through a general template approach that you can use, basically highlighting the critical variants that are important to mention when we're reporting sinus CTs. I will show a couple of cases of inflammatory sinus disease, but mostly I want to highlight some of the pitfalls that you should be looking at, which should raise concern for an alternate pathology. Okay, so CT of the sinuses is a really common investigation, and we get asked to report them day in and day out. And it's important to think about who's referred the scan and why they've referred the scan in terms of determining the level of detail that you need to put into your report. So if this is a GP referral and the sinus scan is basically normal, you don't really need to talk about all of the anatomical variants. You don't need to talk about where the anterior ethymoidal artery is, because this patient is never going to go and have sinus surgery. However, if this scan has been referred to you from an ENT surgeon and there's obvious sinus disease, then it is really important for you to talk about these anatomical variants that I'm going to go into. So when reading a sinus CT, it's really important to assess it in all three planes. Some radiographers will send you axials and coronals and ignore the sagittal plane, but I find the sagittal plane is very useful for assessing the frontal sinus drainage pathways particularly, and it's great to look at them on a workstation where you can get 3D imaging. And the other thing is it's really important to look at soft tissue windows. So if your radiographers have only said to cross the sinus windows, you need to ask for soft tissue windows. So this is important in looking at characterising the contents of the sinus opacification, so things like fungal sinusitis where you're looking for dense material, and also for looking at soft tissue morphology and other characteristics, such as this example of a Pott's puffy tumour where we can see the soft tissue thickening over the calvarium. So the role of the radiologist, I'd hate to admit it, but most ENT surgeons will have a much better understanding of the sinus anatomy and their CT images than a radiologist will, but we do have value to add, and that's basically in picking subtle findings that they might not appreciate, and also in finding pathology elsewhere where the surgeons aren't looking. So in terms of assessing the extent of disease, obviously we're going to comment on which sinuses are involved and how much disease is there. Is there minor mucosal thickening, complete mucosal opacification, and then to also describe the associated bony changes that you see in association with the sinus disease. Also in that, we should be talking about the density of the secretions within the sinus. And so what is normal mucosal thickening? So in the literature, basically 2 millimetres of thickening of the sinus is considered acceptable. So if you've got really very thin mucosal thickening, don't mention it because it's not relevant. And then the other term that we see all the time in reports is pansinusitis, and the surgeons generally don't like that term unless there really is all of the sinuses extensively opacified. So if it's somewhere in between, then you just say there's moderate opacification. So the other thing that we really need to be looking at is the drainage pathways, and so you need to have a good anatomical understanding of what the drainage pathways are, where the ostia are, so that you can assess the sinus pathways. So what you're trying to look for is there an obstructing lesion, whether it's an anatomical variant, a polyp or a tumour. So I'm not going to go over the anatomy of all of the drainage pathways in fine detail. There's lots of great papers and anatomical textbooks that do this, but one I do want to talk about is the frontal recess. So this is a site that's commonly a problem for the surgeons and a common cause for failure of endoscopic sinus surgery. So the frontal recess basically drains the frontal sinus. It has an inverted funnel configuration, and the apex is at the frontal ostium. So the sagittal reconstructions, as you see here, are really nice at assessing the frontal recess, and you can scroll through on a sagittal plane and really get an idea of exactly where the frontal recess is going. So the boundaries, as you see, are the Agonese cell anteriorly, the ethmoid bulla posteriorly, and then the lamina papyracea and middle turbinate in the coronal plane. So we're all very familiar with the osteomeatal complex, so I won't dwell on that too much. Just to mention that the anatomical landmark dividing the anterior and posterior ethmoids is the basal lamella, which attaches to the middle turbinate, it attaches the middle turbinate to the lamina papyracea and is that dividing line between anterior and posterior ethmoidal cells. And then when we come to the sphenoethmoidal recess, obviously there's that small ostium, the sphenoid ostium, that drains the sphenoethmoidal recess medial to the superior turbinate. Okay, so anatomical variants. So we all learnt in first year radiology that there were millions of anatomical variants within the sinuses, and John Erica, one of our colleagues from the PA, published this article and found that 93% of patients on sinus CTs have some anatomical variant. So it's basically normal to have an anatomical variant. So why does any of that matter, and should we be reporting all of these variations? And really, there are just a few critical variants that you need to be aware of that are going to contribute to disease, and also because they're going to get the surgeon into trouble. So we all want to make sure our surgeons or husbands don't end up in the paper. So there are lots of cases of meningitis as a result of complications of FES, patients who have become blind after endoscopic surgery. So it's really important that the surgeon and the radiologist are aware of these variants. So the ENT surgeons are a simple bunch of people, so they like to have a limited number of variants that they think about, and they tend to use this acronym, the CLOSE system, for looking for those critical variants. So what they're looking at is the cribriform plate, the lamina papyracea, whether there's anode cells or not, what the sphenoid looks like, because there's a lot of variants in the sphenoid, and where are the anterior ethmoidal arteries. So probably arguably the biggest role that we have when reporting sinus CTs is to find disease elsewhere. So in this case, this is an allergic fungal sinusitis case. There's a lot of stuff going on in the sinuses, and as you're scrolling through, there's lots of variation in the cells. But what we would hope that the radiologist wouldn't miss is the dermoid in the temporal lobe, but potentially the surgeon might not see that. Okay, so just like in other areas of radiology, there is a lot of discussion about the benefits of using a templated approach when reporting. This article that was published a few years ago now stated that there's significant variation in the way in which CT sinuses are interpreted and reported, but the template-driven approach describes findings which are both beneficial to both the radiologist and the surgeon and improve reports. So there's lots of different articles showing frameworks, checklists, various different approaches to sinus reporting, and some of them are quite complex and can go into a lot of detail. And again, you really shouldn't be reporting in this much detail unless the patient's coming to an ENT surgeon and is actually going to be going and having endoscopic sinus surgery. So first of all, I tend to comment on whether there's been any previous surgery, as in this case, where you can see that there's been an uncinetectomy, middle meatal antrostomy, and anterior ethmoidectomy. So it's a good place to start. Has there been any surgery in the past? And then I tend to move basically from the nasal cavity out. So what does the nasal cavity look like? Is there any septal deviation? Is there a concha bullosa? And other anatomical variants. Probably no one needs to be reminded of this, but there is a normal nasal cycle. We recently had a patient referred for an MR for an abnormal inferior turbinate, which was just a normal nasal cycle, basically. So again, an image of septal deviation. You tend to have a spur on the side that the deviation is bowing towards. And in this case, There's no associated mucosal disease, there's no evidence of nasal obstruction, so you wouldn't even need to report this out in the general community. And also concha bullosa. We all love talking about concha bullosa because it's something that we've found on the Sinus CT, but they're in 55% of the population, and unless it's causing any obstruction, again, you probably don't really need to report it. When we're going into the maxillary sinus, again, talking about the size of the sinus, how well pneumatised it is, whether we can see any defects in the orbital floor are probably the most important things. Haller cells, again, it's one of those ones where we like to talk about because we've found them, but unless there's evidence of obstruction of the infundibulum, then they're probably not worth a mention. The infraorbital nerve, if it's on a mesentery, is potentially at risk during surgery if it hasn't been recognised by the surgeon as it's sitting in the middle of the sinus where they're going to be operating. And then we can have all sorts of anatomical variants. So this is an accessory ostium in the medial wall of the maxillary sinus, and only exciting when you have a pathology in association with it, like this anterochoanal polyp, which was actually extending through the accessory ostium. So we're coming to the more important areas now. So the ethmoid sinuses, so the anterior and posterior ethmoidal arteries are important to recognise. The height of the anterior skull base and whether there's any dehiscence in the skull base. So bony dehiscence is important to recognise, as obviously CSF leak or meningoencephaloceles are an important pathology to consider. So this was a patient who had some rhinorrhea symptoms and has this polypoidal lesion in the nasal cavity, and when we look at it closely you can see that there is dehiscence of the cribriform plate, and this was a nasoethmoidal encaphalocele. Important not to biopsy that one. And then the other place that we see bony dehiscence is the lamina papyracea, and often with sinus pathologies and inflammatory sinus disease you do end up having some bony dehiscence. So the expansile nature of the inflammatory disease causes thinning of the bone, but in most cases the bone will still be intact surgically, but just very thinned by the inflammatory change that's happening in the sinus. So the anterior ethmoidal arteries is a branch of the ophthalmic artery. So it courses anteromedially as it leaves the orbit and then pierces into the lateral lamella of the olfactory fossa. And typically the artery is housed in a bony canal as it courses along the roof of the ethmoids in the floor or in the skull base. So you can recognise it on CT quite easily by these two little triangular indentations from the medial wall of the orbit. And when you look at CTs, most of the time you're going to be able to recognise where the anterior ethmoidal artery is. The time when it's important to recognise is when it's on a mesentery, so when it's not in the roof of the orbit but actually going through between a couple of the ethmoidal air cells. So at that point, that's where the ethmoidal artery is at risk of being affected during an operation. So what can happen is if the vessel is inadvertently torn by some of the microdebriders that they use, it retracts into the orbit, and then you get a retrovulvar hemorrhage, increased intraocular pressure, and then potential visual loss. So it's important for the surgeon to be able to recognise that there is an anterior ethmoidal artery on a mesentery. Then the height of the ethmoidal air cells, or the roof of the ethmoidal air cells, so that's the fovea ethmoidalis, is higher than the cribriform plate adjacent to it. So that lateral wall between the cribriform plate and the fovea ethmoidalis is known as the lateral lamella. And we can measure the height of the lateral lamella, and this is known as the Keros classification. So this is pictured here. So most people have a Keros type 2 configuration, which is basically 3 to 7 millimetres in height. But the type 3, which is greater than 7 millimetres, is the one that's clinically important. So when you have a high or a deep olfactory fossa, there's a greater risk of surgical trauma to the lateral lamella, and the surgeon could inadvertently enter the anterior cranial fossa, causing a subsequent CSF leak. Also, if there's marked asymmetry between the two sides, that can be confusing intraoperatively and lead to potential damage to the anterior cranial fossa. Okay, so we're going to talk quickly about the frontal sinus. So the anatomy of the frontal sinus can be quite confusing, and there's a lot of variant anatomy. So the key to the frontal sinus is the Agonese cell and the frontal beak. So the frontal beak is basically that little bit of bone that you can see just at the origin of the frontal sinus. So you can have a large frontal beak which can cause obstruction of the sinus, so that's important to recognise. But generally there's accessory cells which are causing obstruction. So in this case it's pretty easy to work out why the frontal sinus is obstructed. There's a giant osteoma sitting in the frontal sinus drainage pathway, but in most cases it's quite difficult to work out what's going on. So we have to think about these frontal cells. So there's a bunch of different frontal cells, and they are a little bit confusing. So we have Kuhn cells, which are anterior and above the Agonese cells, and then we have suprabular cells, which are above the bulla ethmoidalis, and they're posterior. So basically, if you can work out if it's anterior or posterior, which is when the sagittal scans are important, then you can work out if it's Kuhn cell or one of the other types. So the Kuhn cells are basically categorised into the number of cells above the Agonese and whether they go into the frontal sinus itself. So the Kuhn type 1 is just one single cell above the Agonese, whereas a type 2 is a little collection of cells above the Agonese but not above the frontal beak, which is there with the asterisks, versus a type 3 cell, which is a large cell which is going above the frontal beak all the way into the sinus. So in assessing these, often you need all three planes and you need to be scrolling backwards and forwards to try and determine where this cell is arising, whether it's anterior or posterior. So as opposed to the suprabular cells, which are posteriorly. So these are rising above the bulla ethmoidalis. So we have the suprabular cell, which doesn't quite make it above the frontal beak, the frontal bular cell, which gets above the frontal beak, and then you have the supraorbital ethmoidal cell, which goes out quite laterally over the orbit. So all of these terms I don't expect anyone to know, but it's important to realise that there is an extra cell, either anterior or posterior, so above the Agonese or above the bulla ethmoidalis, that's obstructing the sinus drainage pathway. So the other difficulty with this is that it's all well and good when the sinuses are well aerated to kind of recognise these cells, but in reality, when the sinuses are heavily opacified, it's really quite difficult to work out what cells are what, and often the air cells are poorly, they've got some bony deossification and therefore they're hard to actually see. So often you can have a little caveat on your report saying that there's marked sinus opacification, making assessment of individual cell anatomy difficult. So, that's your get out of jail card. So quickly onto the sphenoid sinus. The things that we're looking at is the carotid artery and the optic nerve. So they're the important anatomical landmarks back in the sphenoid. So sometimes we see some variation in the sphenoid sinus, the intersinus septum. It may insert laterally, and if it inserts over the carotid artery, as the surgeon's removing that septum, there's a potential to actually open up into the carotid artery canal. So that's a good one to mention. And then also whether there's a dehiscent carotid canal. So if the carotid canal is dehiscent, in reality there's still a bony covering over it, but it's very thinned, and therefore the vessel will be at risk for iatrogenic damage. The other thing that's important to recognise are anode cells. So these are basically a posterior ethmoid cell that's pneumatised quite laterally and superiorly over the top of the sphenoid sinus. So it's intimately associated with the optic nerve and may cause some confusion to the surgeon at operation as to whether there's still more air cells to get into before they reach the sphenoid sinus. So the clues are, again on the sagittal scan, is that the anterior wall of the sphenoid sinus is normally vertical. So that's a normal cell on the left-hand side, whereas an anode cell slopes posteriorly or backwards on the sagittal scan, and that's the way that I find the easiest to recognise an anode cell. Again, Onodi cells can be associated with pneumatisation of the anterior clinoid process, and in this case you can see how close the optic nerves illustrated there in yellow are to the sinus itself. If there's a dehiscence of the optic nerve canal, it's important to know as well. Oops, this is the dehiscent optic nerve canal. Okay, so finally it's really important to review the rest of the scan, make sure there's no pathology elsewhere, such as this choroidal melanoma on CT. Okay, so we're going to, in the last couple of minutes, basically touch on some important pathologies to be aware of when looking at inflammatory sinus disease, and then some of the pitfalls. So I just wanted to run over allergic fungal sinusitis. It's a pattern that you see out in the community quite often. So this is hypersensitivity reaction to inhaled fungal organisms. It's an IgE-mediated response like an ABPA within the sinuses. So it's in young patients. They often have history of atopy, they have chronic headaches and nasal congestion. And the things that we're looking for is this hyperdense material within the sinus. The sinuses are expanded and there's bony remodelling within the sinuses. And again, we've seen this case already. There's multiple areas of bony dehiscence, particularly in the frontal sinus, and the sinuses are expanded and hyperdense. So this is a classic picture for allergic fungal sinusitis. Versus the other one that no one ever wants to miss, and that's invasive fungal sinusitis. So this is a rapidly progressive infection in immunocompromised patients or patients with poorly controlled diabetes potentially. You rarely see it in a healthy individual. So in the hospital setting, we see a couple of cases of this every year, and it's really important for us as radiologists to recognise it, because often the ENT registrar who's on may not recognise these subtle features as well. So one of the commonest places that you see invasive fungal sinusitis in the first instance is in the retromaxillary fat. So you get abnormal inflammatory change in that retromaxillary fat. That is what you're looking for on the CTs. So everyone sort of thinks that it's going to be some really aggressive looking process, but it's often quite subtle. I'll just go back to that one. So this loss of fat there in that retromaxillary region is really the only sign on this that you can say that there's invasive fungal sinusitis. And then when you give contrast, obviously there's a lot more enhancement, and it's beyond the margins of the sinus and anteriorly into the premaxillary tissues as well. And then the last little pathology I want to talk about is inverting papillomas, because often it's hard to distinguish, is this a polyp or is this an inverting papilloma? And these are locally aggressive but pathological but benign tumours. And one key that I've found useful in looking for inverting papillomas is this little bit of hyperostotic bone. So there's some research that says in 99% of cases of inverting papillomas, you will see this little hyperostotic piece of bone, which is the stalk where the inverting papilloma arises. So that's a great thing to look for when you're looking through your sinus CTs. Okay, so we're nearly at the end. So firstly, I really want to sort of talk about some of the pitfalls in sinus imaging and show you a few cases in which it could have been easy to miss more serious pathologies. So one of the most under-recognised causes of inflammatory sinus disease is odontogenic sinus. So in this case, this person happens to have a nasogastric tube in for another reason, but they've got maxillary sinus opacification. But when you look carefully, you can see that there is a periapical abscess in association with one of their maxillary teeth, and this was sinus disease because of dental disease. So that's a common cause for maxillary sinus opacification. So always look at the teeth. And again, another case where we can see it's a unilateral maxillary sinus disease, and we can see the little periapical abscess in association with that tooth. So in this case, this was a gentleman, he was in his 40s, he presented to an external hospital with headaches and had this CT, which was basically reported as normal and said to be minor mucosal thickening. And then a year later, he came back to a different hospital, had another CT, again, minor mucosal thickening in the posterior ethmoids. And then a year later, he comes in with some epistaxis and nasal congestion and has this CT, which now shows more progressive mucosal thickening. And when we look at the coronal scans, we can appreciate that there's an actual mass in the nasal cavity. It's broken through the cribriform plate, but is extradural still in location. And this ended up being a spindle cell sarcoma. So I'll just go back to that. So probably on the first scan, that would be pretty harsh to expect someone to be able to pick that up. But on the second scan, that area of where that opacification is the olfactory recess. So it's basically the little area between the septum and the superior turbinate. That area in the midline there really shouldn't have mucosal disease in it, or no significant mucosal disease. So if you see a pathology isolated in that location, you have to start thinking, is it something else? So esthesios and other tumours in the nasal cavity often arise in this location. So it's one spot. If you've got isolated disease there, you have to kind of start raising red flags. So then this is another case. This is a younger guy. I think he's about 30, again with some nasal congestion. And potentially you could think that this may be a mucocele. You've got expansion of the maxillary sinus, but when we look closely, we can see that the bone of the medial wall of the maxillary sinus is eroded, and you've got erosion of the hard palate. There's erosion of the tooth roots, and this is quite aggressive. Like Mitesh was talking about before, the bones become splintered. There hasn't been a chance for remodelling. The whole of the tooth root's been completely eaten away. And again, we've got expansion out into the premaxillary tissues, which doesn't happen very often with inflammatory sinus disease. And this ended up being an adenoid cystic carcinoma. So this fellow had a maxillectomy. We can see there the greater palatine nerve with the arrow on it looked completely normal at this point. And unfortunately, a couple of years later, he's had a recurrence with perineural tumour spread in the pterygopalatine fossa. And again, another case where there's just some sinus opacification in this right sphenoid sinus. Looks pretty indolent on the CT, but when we scroll more posteriorly, we can see that there's erosion of the clivus. So that subtle bony erosion, which I'm not going to show you all of the axial scans, but this ended up being a plasmacytoma. So it's really important to look at the margins of an opacified sinus to make sure and check for any associated bony erosion. This was a case that we saw this week, so I thought I'd put it in, and I don't have a CT correlate for it. But in this patient, there's fluid basically in the posterior aspect of the sphenoids. And when we look on the coronal reconstructions, you can see that there's actually a defect in the lateral sphenoid wall, and this is a lateral sphenoid encephalocele. And this patient actually has one on the other side as well, so bilateral sphenoid encephaloceles, and has a CSF leak associated with that. This is one of the last couple of cases. This is a patient in hospital with acute sinusitis. This one's not too hard to spot, but you can see in that retromaxillary fat on the other side. Oops. There, we've completely lost all of that retromaxillary fat, and this was another case of invasive fungal sinusitis, and you can see here in the region of the infratemporal fossa, the fat is completely lost. So that's another key sign to look for, particularly for the invasive fungal disease. And then again, polyps, always be wary of polyps in the nasal cavity, and always make sure that you look at the cribriform plate and make sure it's intact. And this is another encephalocele. Okay, so another case where you could potentially just scroll through and say, oh, yep, there's pansinusitis, it's all opacified. But when we look closely, the septum is completely gone, there's erosion of all of the turbinates, there's dehiscence of the lamina papyracea on both sides, the anterior skull base is gone, and again on the axial plane, the same findings, and this was a diffuse large B-cell lymphoma. So this one I quite like. So this guy came in after being punched in the face. He was only 15, came into hospital, had some gas in his soft tissues of fluid level, which is what you'd expect after you've broken your nose. And what wasn't appreciated on this scan was this opacification at the back of the sinus. And this little area of bony dehiscence near where the Vidian nerve canal is going into the pterygoid plate. And you can see on this, it's not a fluid level, it has a bulging contour, so this is more polypoid or mass-like in contour, And when we rescanned him a couple of years later after he developed epistaxis, this was the lesion and this was a small JNA. Again, another case of an acute sinusitis where we're seeing that really aggressive bony erosion, so not the sort of thinning erosion that you see with inflammatory sinus disease, but more aggressive erosion of the medial maxillary wall. Again, you can see that the erosion's going down into the hard palate and that maxillary alveolus, and this was a Ewing sarcoma. But same, you know, all of these are different pathologies, but just showing that aggressive kind of bony erosion that you're looking for. I might skip forward this one. That was a nice case of an LCH, but I just wanted to show this. So this is that LCH case, and you can see on this one, there's the aggressive bony erosion as opposed to a mucocele where you have that thin, smooth, bony expansion. And finally, another case of fungal sinusitis, because we don't appreciate it well on CT, so I'm just labouring the point here. So that retromaxillary fat, this was a case last week, is what you should be looking for. So this is the key sign for invasive fungal sinusitis, and often you will have a pacification in the posterior aspect of the nasal cavity as well. And then the associated MR, just showing the disease which has progressed into the orbit. So in summary, there are lots of anatomical variants. I don't expect everyone to spend their whole reporting session talking about them. The ones that are important are the cribriform plate, the lamina papyracea, the Inodi cells, and whether there's any variants involving the sphenoid sinus, particularly the optic nerve and the carotid, and looking at the position of the anterior ethmoidal arteries. You always have to look for disease elsewhere that the surgeons are going to miss, and always be aware of that destructive bony change, the retroantral fat, and whether there's any other signs of soft tissue infiltration. So thanks to Mitesh, who's given me a lot of my cases, and all of the staff at both the PA and the Royal where I've collected these other ones from. Thank you.
Thanks, Jen. So next I'd like to welcome Dr. Ryan Somerville to the stage. He is a ENT and skull-based surgeon based in Brisbane. He works at both the Royal Brisbane and in private practice. He trained in Queensland before completing a fellowship under, I've got to get this right, Professor Giovanni Danisi in Bergamo. That'll do. In Italy. So thank you, Ryan.
Thanks very much, Cameron. Certainly it's a pleasure to be here and pleasure to have another opportunity to spend a weekend with my wife. I did recommend that we should, I put forward a proposal that we should have a team tracksuit, but we discussed that, an equal and open discussion, and then she decided we wouldn't do that. I just need to change the screen resolution. Dude said he would be here to change it. Where is it? I'm going to break it if I do it for sure. Oh, that is to change the screen resolution. Hey, not quite seeing the desktop. Just not quite seeing the desktop, but not seeing everything. Lovely, thank you. Thanks very much. So, let's get rid of all of that. Try and change it. Okay. So what we're going to do with this talk is I'm just going to present a bunch of cases. We're going to look through, from my point of view, a bunch of cases that have some operative videos in conjunction with the scans. We're going to be switching back through the Osirix also to the operative videos. So to start off with, as I said, there is going to be some videos. I'm going to try and put in what I think is the goal for each case. I'm not going to go through the radiology of every single case there because I'm not going to teach you guys how to look at the scans, but just really what the particular feature of that scan, hopefully there's one feature of each scan, each patient, that is going to change the operation from my point of view. So this is a lady who's had surgery over 15 years, 4 previous operations by 3 other ENT surgeons, all more senior than me. and she continues to get right frontal pain, and she'd had that last operation 5 years ago, and she uses daily endone. And so the question was, why is she getting the continuing pain? What am I trying to achieve with this patient? And this patient here, I'm trying to resolve her pain, of course. Everything else had been done before, and so who am I to say that I can do the job better than the other guys? But what I'm really looking for, oh, this is all completely wrong. That's good. So I'll just start that again. This is great. Okay, I'll just have to... So what I'm going to do is just try and scroll through the cases here. I'll just leave it on that. In this particular patient, what we can see here is that she's had previous sinus surgery bilaterally, quite a lot of disease, but the residual disease in her is just here on the right frontal sinus. And the frontal sinus drainage pathway is really where I've got that little marker there, and that's where we need to clear. If we don't clear that and end up in this nice broad frontal sinus, then we're not going to achieve what we want to do. And as Jenny said, there's a frontal beak, there's a little piece that's poking laterally there, and that's what we need to clear before we can get her resolution of her pain. So if we go back to the scan, so this is using stealth imaging. So in the stealth imaging, we can identify the anatomical features of the patient intraoperatively using some preoperative stealth protocol scans, and that's with the MR and CT. And you could see in that one there, previously there, I couldn't get up into the frontal sinus. So what we can see here is it's quite a lot of previous disease, a lot of scarring. Frontal sinus is up this way. So we're trying to make some room in what we call the axilla, which is the space between the middle turbinate and the lateral wall of the nose. And the frontal sinus drainage pathway is here, but it goes forward and then it comes backwards on us and goes a bit lateral as well. So you can't just go straight there, you've got to make a bit of room. So this is the suction, and I can't really get up very far. If we don't get up very far, then she's not got enough space. You can see there's a bit of space here. That's not quite enough, because what will happen is that will circumferentially scar down. She'll end up with the same symptoms again. So we have to drill out that frontal sinus beak. So I'll just save you a bit of my drilling here, because we had some problems with the imaging before. But as you can see, as we're progressively broadening that, that's actually that frontal beak that we're seeing just up here, projecting posteriorly. A little bit more expansion of that frontal beak. And a bit more space there. And at the end of the video, what we'll be able to see is quite nice up into the frontal sinus. And then the stealth navigating instrument up into the apex of the frontal sinus. So that's where see that little X, I don't know if you guys can see that green X there, the cross mark. That's me up into the frontal sinus. That means we've been able to get up all the way through where we need to be. So the next case is another patient who had previous surgery overseas. He had 3 times. He had a lot of pain with his last operation. He stayed in hospital for about 5 days post-operatively. And the question was, why did you stay in hospital so long after a sinus operation? What was the pathology which you didn't know? And what am I going to do to make it better this time? Once again, the 4th time round. So in this particular patient, so I'll just scroll these. Oh. Sorry guys, I checked this before. So this particular patient on that right-hand side there, you can see that it's got a large polypoid type mass. There's a hole here, which is an inferior meatal antrostomy. So someone's gone through underneath the inferior turbinate into the maxillary sinus there to access the maxillary sinus. And so that usually, if you've got a polypoid mass there, I would assume that's going to be something like an antrochoanal polyp or an inverted papilloma. He really had no idea what it was. And then on this imaging, on the axial imaging as well, you can see that there is the inferior meatal antrostomy coming up to the inferior turbinate, and then above into the maxillary sinus, normal ostium, which has been greatly widened, and a big expanding polyp pushing the middle turbinate immediately there. So for me, the important thing is, one, looking at the features of this previous surgery, were there any anatomical features that are abnormal? You can see the anterior ethmoidal artery is on a mesentery, not quite as bad on the ipsilateral side as the contralateral side, but it's something to be aware of. And knowing that there's a pacification of the whole of the right side. So that's a little bit abnormal for an antrochoanal polyp. Hard to know what to expect until you get in there. So this gentleman's video, you can see here now, this is the appearance of a normal, boggy, wet-looking nasal polyp. That's the inferior meatal antrostomy coming under the inferior turbinate, and then the polyp appearing from the middle meatus with the middle turbinate just here. So this is the right side, of course. So what we're going to do now is try and debulk the polyp, trying to find the base of it. If you don't find the base of the anterocoinal polyp, then you don't get disease control. And as I get through there, you'll see that there's some previous scarring. It's a really big maxillary sinus ostium. There's a bit of scarring, and that's a bit of a stump of an old ethmoid sinus cell that's been taken down. And I'm really just trying to find my way and work out where everything is. So once we've done the transmaxillary, we're through the middle meatus, going underneath into the inferior meatal antrostomy, taking down that polyp, and once again trying to get a view. So what I've done here is clear basically all the mucosal sites. So now I'm not looking to clear out that blood or anything there. It might bother you guys seeing a bit of blood, but from our point of view, it's really trying to see if there's any residual disease that might be the base of that polyp. It was quite difficult surgery, went quite nicely, but it was a bit bleeding, so we're filling that now with some hemostatic material called Surgiflow to try and reduce any post-operative bleeding. Days are gone where we have to do packing of the nose that needs to be pulled out in long ribbons. This gentleman here has a completely different history. Once again, though, he's had previous surgery. His big problem is the oysters that go down the back of his throat every single day and the dead smell on his nose. So what am I trying to achieve? Well, I'm trying to get rid of that for him. So you look in his nose from an examination point of view, it's very thin, floppy-looking septum. Whether that's from surgery or from the disease, it's hard to know. A lot of crusting and gunk in there. And he basically failed medical management, which for us includes oral steroids, topical steroids, macrolide antibiotics over a long period of time, nasal douche, and then we get a CT with stealth for surgical planning post-operatively. So if we look at this gentleman's scans, I'm sorry, we're going to probably have to fix the pictures again. What we can see on his situation is the anatomy is the problem in this man. So on this slice, you can see that there is a large left frontal sinus. There is basically no frontal sinus on the right-hand side. So I need to know that's there. If I keep poking up this way, I'm not going to really get very far. It might cause him problems. And on the left-hand side, we obviously need to clear all the way up there before we can clear the disease. I'm going to focus on that left-hand side. So from this point of view, the one slice that's important is this slice here. So that cell there, the bulla ethmoidalis cell just here, is the key to the whole operation. If we don't take down that bulla ethmoidalis cell, we don't get up into the frontal sinus. So you can see that the frontal sinus drainage pathway, or the frontal sinus we start up here, is there, goes medial to that bulla ethmoidalis cell, lateral to the middle turbinate here, and then passes down into the infundibulum. So if we don't clear that bulla ethmoidalis cell, then you don't clear the disease. And you can see them when you look through. We tend to use all three images, like Jen said, all three slices when we're preoperatively planning, trying to create a 3D picture in the head. Medically, legally, we have to have the scans up either on the computer or on the wall, because if there's a problem, then you can't say you're doing it very well if you don't have the scans available. But the reality is that most of us create a 3D picture which was described by a guy called Professor P.J. Wormald in Adelaide. It's about getting little sort of blocks and then working out in your head where the blocks are in relation to each other, and that's in 3 planes, so it's this way, that way, and above each other. So it's quite complicated, but that's how we approach sinus surgery. So if we go back to his video, the other thing about that guy that we probably didn't realise, well, I didn't realise, that was the case that Jenny reported with the dermoid in the middle cranial, in the temporal lobe. And it was my case, and I did miss it. I didn't see it. But I did read the report. So once again, you can see the previous surgery there. A lot of scarring. It's all cicatrised down. He's got obstruction again of whatever they've achieved last time. This is the polyp sitting in front of that bulla ethmoidalis cell. So we're just going to get now to the important part of it. So this is using a curette. We're moving in a medial to lateral direction. It's a safe direction. If we go lateral to medial, you're going to go through the cribriform plate and you can have a CSF leak. So this is taking down that bulla ethmoidalis cell just there. The important bit is to get that roof of that cell that we saw. And if we now look upwards with an angled scope in just a moment, we'll be able to see up into the frontal sinus, and it's completely clear. So he had complete resolution of his disease. So it's about working out where the important point in that person's scan is. So this is a very unfortunate young girl, very lovely young lady. She's had 4 surgeries prior to meeting me as well. She's got very complicated medical management, which includes her for asthma, which is a horrible situation. She's quite active. She teaches gymnastics, and she's in hospital every now and then for her asthma. She had her first FES at 16 years of age. So she's on all these medications here, which are really, some of them are high-level stuff, like the omalizumab was actually something that the immunologist had to apply for on a national level purely for her case. And it controlled her disease for a little while, but unfortunately I saw her about a week ago and we're looking like we're going to have to go back in again after getting disease control for a few years. So her disease is very difficult, it's very hemorrhagic. What am I trying to achieve? Well, I'm trying to achieve complete removal of her polyps. I fully believe that in these sort of patients, if you don't get all the polyps out, you don't control the disease, you're just chopping the bottom of it off. Your body can't control it, the medications can't control it, and it all just comes back. So really what we're trying to do is get in there and fix it. And the first time I went in there, I didn't appreciate that. She was on steroids, none of the other stuff, and I bailed halfway through the operation because it was just bleeding, hemorrhagic bleeding had to stop. Couldn't see anything. So if we look at her scans, similarly again, we're going to try and find what the most important part of her imaging is. And in her situation, just to keep it simple, that air cell there is the key to the whole operation there. So what I'm trying to get in her, all this sort of stuff below here is pretty easy. We can get that in no time. We don't really need stealth imaging for that. It's really about that particular air cell there. And you can see that the frontal sinus drainage pathway for her is this little slit just here. So if we follow that up, that leads us into the frontal sinus. If we don't go here in the right direction, what you're going to do is you're going to see the roof of that air cell and you're going to think you're in the frontal sinus. Oh, it's a very small frontal sinus, but it's not. It's actually an ethmoid cell that you haven't actually gone through to get to the frontal sinus. If you go the wrong direction here through this bone, which is 0.5 millimetres thick, you're going to get a CSF leak. So we've got to go in the right direction up like that. And so if we go to her video, once again, patient's right-hand side, a lot of scarring through there. These polyps are not too hemorrhagic, and that's after 6 months of planning. And so we're able to do the operation quite safely. So we're getting to the bottom of where everyone's achieved before. You can see here, a bit of scarring up through there. This is basically just above here in the ethmoids is where I was able to achieve last time. See all that scarring through here. And everyone stopped about here. No one else was able to get through there because of the severity of her disease. And in a moment, what we're going to see is that air cell. So this is that air cell right here. So where's the frontal sinus? It's inflammatory, it all looks the same, and the frontal sinus is just coming up just here. So that little chain, that slightly smooth mucosa just in there that I pushed up through is the pathway that we need to look for. So we need to go around that and then pass laterally. So if I don't appreciate the shape of that air cell and how it sits in relation to the frontonasal duct, then we're not going to be able to achieve this or potentially cause problems like CSF leak as we discussed. So same thing again, take down the roof of that air cell and we're able to get into the frontal sinus. This gentleman presented with no history of sinus disease but had quite acute infective problems. He was very, very unwell, was admitted to the Royal Brisbane Hospital and then transferred privately, and he presented with the symptoms you can see there. So I'm trying to fix his acute inflammatory infective problem. So this gentleman, we can see there's heterogeneity in his maxillary sinus, expanding and filling his ethmoid sinuses there and going up into his frontal sinus. The key in this gentleman's scan is this bit here. So you can see that he's got erosion of the laminar papyracea. So if we're using that microdebrider that you saw me using quite a lot, if we use that in that area there, you're going to suck in the periorbital. The next thing you see is periorbital fat, and the next thing you see is either medial rectus or superior oblique. And if that happens, the patient has permanent diplopia for the rest of their life. It's very difficult to fix. And so being aware of these sort of things preoperatively obviously is important. And I was called to assist just recently in a patient who had just that sort of thing happen, but they didn't, fortunately didn't have any problems with the actual muscles. It was just periorbital fat and an anterior ethmoidal intraorbital bleed, which we fixed for her. So this is at the end, basically after I've removed all that inflammatory disease. And that's because I didn't show you that bit before because it was full of blood, it was red everywhere. But just here is the dehiscent lamina. So we're going beyond all that. There's leaving a little bit of disease on the lamina there. We're not taking that down. And obviously, if I didn't know that was there and I was using that microdebrider, stroking like we do, pulling across that lateral wall there, it's very easy to suck it in when it's moving at 5,000 revolutions per minute. And then you've got a medical legal problem. So the next patient is also quite interesting. He had 10 years of problems bilaterally, nasal obstruction. The left side was always worse than the right. He's a friend and a colleague, he's a fellow medic, and he gets recurrent sinusitis every year. So I treated him with our maximum medical treatment, got good resolution of symptoms on the right, residual symptoms on the left. That should have been a sign for me to know that there was something funny going on, but I didn't get it. So looking at his scan here, you can see that there's that unilateral polyp that Jenny talks about, the skull base is intact. It really just is a big polyp that looks like it's filling that side. There are some changes on this side over here, and you think, okay, maybe it's just worse on the left than the right. So once again, looking at his anatomy, here you've got an anterior mortal artery that's on a mesentery. I was aware of that. That's fine, there were no troubles there. Don't worry, there's no medical legal disclaimers coming up with this patient, but you can see that it's quite different anatomy. There's a little bit of demineralisation of the bone here, or maybe that's just because of the level of pacification. But in any case, we'll come back to that in just a moment. This gentleman's video, I had to do an endoscopic septoplasty. This is another sort of sign that on the scan the septum looks very straight, but anatomically when we go in there's not much room there. You can't fit a telescope in here with the septum pushing laterally. So I did an endoscopic septoplasty, gives us a bit of room, and then we can approach the polyps just behind that. These look like relatively normal polyps. They're white, they're sort of pale looking, but then we get here and this is when it started to look a bit funny. So you can see those polyps look different. I knew that straight away, but I looked back at the scans, didn't quite appreciate at that point in there, but it's starting to look what we call beefy. It's very granular looking. So taking down the Agonese cell and then trying to find the base of this disease. Skull base coming up just behind there, knowing that the anterior mortal artery is running on a mesentery right in the centre of where this disease is. So it looks very rough here. So why is it looking rough like that? Frontal sinus up there, no problems getting through here, but this is the problem. So clearing all that disease underneath here. And this is the air cell. Just underneath there is the air cell that comes behind that dehiscent, that anterior mortal artery. If I take down that anterior mortal artery like this now, with the view that you have there, there's a high likelihood of causing a bleed of the anterior mortal artery, retracting into the orbit, and then having an intraorbital bleed and potentially blindness. So I did what I could to get through this part here, but the reality was the key was always in the radiology. So as Jenny mentioned, that slice there, sclerosis just above the anterior mortal artery, sclerosis. And so this was an inverting papilloma. And so what we did then was we did a stage procedure, second stage. I took the anterior mortal artery as it came out of the orbit, resected all of that stuff there, and he continues to be free of disease. So as Jenny said, if I was able to get the base or knew the base was there on the first instance, then I'm able to control his disease. So this is a gentleman who's had previous surgery. We're going to move backwards through to the skull base a little bit now. Previous surgery, and he's had a sarcoma removed, had post-operative radiotherapy, he's had a flap put in there, and he's got a recurrence. He presented with nasal obstruction and nasal bleeding. And so he had a biopsy done by another surgeon in our unit, came back as hemangiopericystoma, which can occur sometimes after previous surgery, like in a sarcoma with radiation treatment, it can change in its morphology. So hemangiopericystoma is benign, but it requires surgical excision. If we don't get clearance of this tumour, then it recurs. So once again, you've got to make sure we understand the anatomy of what we're looking at here. Oops. So if we look at this MR first, we can see there's a lesion on T1 that's iso-intense to brain. It does seem to be pushing up into the middle cranial fossa, is expanding that bony space through there, filling the middle, the sphenoid sinus on that side as well. It's also quite iso-intense on T2 and is very bright on contrast. So it's a very vascular lesion, we know that. There was no chance for embolisation, unfortunately. But then if we look at the CT, the other thing that's important is that you can see the demineralisation and infiltration of that bone. What I do with these cases, I always actually talk to Jen or Mitesh about these sort of cases to basically say, look, I know I can do all this stuff here. The question is that little bit there, and I'm trying to understand, is there a dural plane there? And these guys have to make a call on it quite a lot, but to be honest with you, they're mostly correct. And so if we So I just want to show you the previous surgery. You can see as we come forward, there's the denervation change of the pterygoids and the infratemporal fossa, and the flap coming through here. So you're going to expect, this is a very abnormal nasal cavity, which we'll see in a moment. He's got no septum left, he's got really nothing left there, and it's going to be scar as we approach the back end of that, and then immediately go back into where that tumour sits, coming off the front end of the sphenoid sinus into the pterygopalatine fossa. So this is that area. So this is midline. This is looking to the left nasal cavity. There isn't no left and right. There's just one single nasal cavity. Now looking towards the back where the sphenoid sinus is filled by that tumour. And on the scans, one of the other things we had to appreciate was is there a bony, a layer of bone underneath the internal carotid artery, which there was in the sphenoid sinus, but there wasn't anterior to that, just as we saw that lateral bit going to the middle cranial fossa, the anterior part of the cavernous sinus. So I'm trying to find a margin, trying to see, does this tumour dissect? Can I dissect it off like that? And as you can see, it wasn't going very far. This is that microdebrider that we saw quite easily chewing up those polyps before. I spent half an hour doing this and it looked exactly the same. So a very hard tumour. It's not going to work to dissect it like that. So it needs margin dissection. We need to get around the whole thing and mobilise it everywhere before we're going to be able to get that out. And so now we're clearing the sphenoid sinus, the last little bit of disease, a lot of blood, but unfortunately that's the way it is with this sort of case, particularly if with previous surgery, previous radiotherapy and a vascular tumour. So clearing the last little bit of disease is coming from the sphenoid sinus and then looking up towards where we're going up towards the middle cranial fossa. And in a moment we're just going to see just a hint of where we're looking up towards the dura. And that's the first hint of dura is going to come up just in here. That's dura just there. So we've got to dissect all this sort of stuff off. It's going underneath the orbit and posteriorly there. And that's orbit clear. With the Doppler, we found that carotid was sitting about 2 millimetres back through here. And he did not have radiation to the back end of his tumour until we were able to give him some extra dose there. And 4 years later, he continues to be free of disease. Oops. So the next patient, as my last patient, is a patient that just came in recently, sudden onset, 3rd, 4th and 6th cranial nerve palsies, otherwise normal lady with no other medical problems. And the imaging reveals a cavernous sinus lesion. So in this particular patient, the question is really, we hear cavernous sinus lesion and we hear that the patient has multiple cranial nerve palsies. And pretty much everyone says, well, see you later then, it's nothing we can do about it. Cavernous sinus being, as Ben described, Ben Panizza, one of my mentors, is here in the audience. The cavernous sinus was described today as a bag of blood. And so you get just absolutely torrential bleeding, not to mention the carotid, not to mention all the nerves that are running through there that we can potentially damage. And if you can't see it because there's blood everywhere, then they're at risk. What we can see, though, is that there's a lesion. The CT is completely unhelpful. The bone surrounding is pretty much intact. There's a lesion that's iso-intense on T1. It's pushing the normal pituitary to the other side, and it's behind where the carotid turns, just laterally there in the cavernous sinus. So we can find a little corridor just behind the carotid where we can get to the lesion. So we can see that here, and with contrast, pushing the normal pituitary that way, stalk coming up behind, just a little bit there. So we went in to try and find that lesion. And this is her. So what you can see straight away, this is not surgical trauma. That's the medial opticocarotid recess, and there's abnormal tissue coming out through that. So there is some major process going on. So normal pituitary over here coming underneath where the clivus is, drilling up underneath where that lesion sitting is there, taking off a little plate of bone to expose the lesion. And you can see that it's quite vascular. Carotid is sitting just across here, optic coming across there like that. And so as we often do with this sort of situation, we buzz the surface of the lesion to try and reduce the bleeding. Incise the lesion itself. This is commonly how we do a pituitary as well. And then take a biopsy. And a bigger biopsy. The first biopsy was a neurosurgeon, the second one was me. So we got that back, and it was a diffuse large B-cell lymphoma. So she started treatment. She's got no other disease. hopefully she's going to get resolution of her ophthalmoplegia. So on sinus CT reports, Jen and I talk about this sort of thing a lot over dinner. It's very exciting. So I think it's important to talk about the anatomy. I don't think there's any point in doing long reports when there's nothing wrong with the patient. So I totally agree with Jenny there. All these sort of things, though, are important. As an example, the Anode cell my younger brother had, an Anode cell on bilaterally and bilateral anterior ethmoidal arteries on mesenteries, and he had surgery done by one of my friends. And so I'd made him write on his head, don't forget the Anode cell, just in case, because it's just so important, it's very easy to miss. We don't look at the other stuff. I really only look at the sinuses. So you guys need to check those other things for us. And those other pathological findings, as we said. We probably look at scans more than most people, even more than probably most ENT surgeons, but they are very important to look at. I don't like the pansinusitis. It gives me no information at all about what's happening with the patient. The Lund-Mackay score is something that was developed over in the UK, and it gives a score for each sinus on each side as to how bad the disease is. I similarly find that completely unusable. What I like is to describe it like it's a picture. I don't like the paragraph report, which is one long thing, and we can't really see the key details. I don't expect you to waste time, like I said, and I don't expect wordy description to minor disease. I do like the frontoethmoidal drainage pathways if it's important for the patient. If there is a large bulla ethmoidalis pushing the frontoethmoidal drainage pathway immediately, and if there's disease there, of course. And I like the sinuses separated into little, not long paragraphs, but little sections so that I can quite easily skip from maxillary, ethmoid, frontals, sphenoid, and then a little summary at the end, and then important findings bolded within the body of the report. So hopefully you guys have got an idea of how we look at scans, how we use them. We do actually spend quite a lot of time poring over them and creating that 3D picture in our head, and particularly for people like Ben and I, where we're operating against dura, against the carotid, and things like that. It is really very important to have quite high quality scans, and I'm certainly very lucky to have Mitesh and Jenny to assist me. So thanks very much. It's goodbye from me and goodbye from her.